medical management of caries. And the goals today, in a very brief time, we don't have a lot of time together in the next 45 or 47 minutes, I'm going to give you an introduction to these topics, which are the background and history of caries management, the conceptual framework for what I call medical management, about caries risk and early caries detection for our patients, a little bit about biofilms, which is going to become a much more important subject going forward, and then using medical management in our restorative treatments. All of us are involved in all these areas. Prior to get starting, let's talk about what are the biggest trends. And I think after social distancing, as they say, after COVID has run its course, we'll be accelerating some of these trends. The consolidation, the growth of large group practices, a gigantic trend in the profession, the biggest trend. Technology integration, big data, I'm really excited about that. And I don't have time to talk about these subjects today, but another time we'll talk to you about using big data, about using artificial intelligence, about clinical decision-making, using data from others' experiences. A lot of good will come from that. Payer system changes, quality, outcome metrics, and how that will determine quality of practices and improving the health of our populations. But today I'm going to talk to you about another big trend, which is medical management of oral disease. This has been on the top of my mind for over 2 decades, and I see it an accelerating trend. And my real goal today is to convince you and to get you hopefully to agree with me of why we're going to see a gigantic movement towards medical management of disease. So let me give you the conceptual framework right at the beginning. This chart shows you what I'm talking about. So if you can follow my cursor here, where I'm circling traditional operative dentistry. Maggie, you can see me moving the cursor there, I think. Traditional operative dentistry. That's most of how we treat caries. So if you think about the fact that dental caries is a disease, and it's the results of that disease that we're treating. So in other words, it's sort of like our house is being destroyed and we're fixing the house after the roof's burned a hole through it. We're not preventing that from happening. Yet there are all these conditions or things that exist prior to the cavity that would allow us to actually treat it before if we could actually see the disease earlier. So the big problem is we can't see the disease often until it manifests itself as a hole in a tooth or a cavity. So we do traditional operative dentistry. Yet we now know we can do more minimally invasive restorative techniques, and we can do a lot of things like remineralizing and using new drugs that we'll talk about briefly today, and controlling the biofilm itself. So there's a lot of less invasive things that don't involve surgery that we'll be doing a lot more of in the future. To give us some perspective, I want to kind of go to the broader view from the public. If you go back 20 years to the turn of the millennium, Life magazine did a review from scientists. They asked historians and experts, what are the biggest trends in the world? What changed the world more than anything else over the last 1,000 years? They said, look back 1,000 years and tell us what were the biggest, most impactful things in the world. So at the top 100, and you can look up this list online. So we're talking a lot about vaccines. Turns out vaccines were deemed, the polio vaccine, the smallpox vaccine specifically, was deemed the 13th most significant event of an entire millennium. Anesthesia, surgery without pain, was the 93rd most significant event invented by a dentist, as you probably know, in 1846. But the most significant event of the entire 1,000 years, looking back the year 2000 to the year 1000, was the printing press. Makes sense. That was more impactful than anything else. More impactful to that point than computers or anything was the printing press, to print books, to print newspapers. And the thing that struck me when I saw this, I said, yeah, that makes sense. And then I said, well, that happened in 1455 in the first half of the millennium. That means that everything that happened after that was deemed less significant than that. Yet we tend to think as scientists and clinicians that all the discoveries that are more proximal to our time have to be more important because they were built on the science from before. Yet nothing was deemed more impactful than that thing that happened in the first half. So I started thinking about dentistry. What about our profession? Are we too focused on what we think are the big advances and maybe we need like a really big change in the profession? And then I saw this publication in 2006, which talked about the discoveries of the year, the science of the year from Science News, which collated all of the top science stories of the year. And in that particular issue, there was a picture of a tooth. And I looked at it and I said, why would a tooth be so important that it's one of the top stories of the year in all of science? And it said that they discovered in Pakistan some of the oldest examples of dental work, 11 teeth with drilled holes dating back as far as 9,000 years. So 9,000-year-old cavity preparation. And I'm thinking, isn't that what we do today? We wait for the disease to manifest itself with a hole. We can't see it till then. There's a hole, and then we fill the hole. Yes, we have better techniques, and as mentioned, we have anesthesia, but it's still restorative dentistry. And then in 6,500 years ago, they discovered beeswax was used to fill the holes. So maybe we just didn't know how they did it before. But this is old stuff conceptually. We wait for the disease to manifest itself. We wait for the roof to burn. And then we fix the house afterwards rather than preventing the disease, really, because we can't see it until that stage. Later on, a few years ago, it was discovered there were 14,000-year-old cavity preps. This is a 14,000-year-old specimen that was discovered where they actually prepared a tooth that had a cavity in it. So what we're doing today, the bulk of what we do in dentistry is old stuff. So I started looking at my own list based on talking to audiences I've spoken with about this subject of what are the most significant events in dentistry in the last 100 years from a technological standpoint. And people gave me things like anesthesia, high-speed handpiece, that's the drill, the fluoride, acid etch technique to prepare teeth for restorations, light polymerization, and maybe implants, CAD/CAM dentistry. Now, if you look at this list, and it's probably a good list based on audience responses, everything on here except for fluoride is about restorative dentistry. So all of the major advances pretty much in dentistry are based on dentists fixing destruction of teeth that has already occurred, not preventing it from occurring, with the exception of fluoride. And the directional change is mainly in the restorative side as well. I think that's all going to change. I think we're going to see, looking back 10, 15 years from now, that the biggest change is going to be treating caries as a disease, the medical model of caries management. And I'll explain that. If you go back historically in the world of caries prevention, you can see that Miller, who was the first sort of dental microbiologist in 1882, he worked in the lab of Robert Koch, the person who, you know, talked about bacterial transmission of disease. His postulates are famous still today. Miller said in this definition of caries that it's a chemico-parasitic process, that it involves softening residue through bacterial acid production. So we knew 140 years ago exactly how caries occurs, that it's a process microscopically, slowly eats away underneath the surface, and then the tooth cavitates. Yet we still treat it as if we can't see it because we can't see it clinically. That's all going to change. Even G.V. Black, who's the father of modern restorative dentistry, he talked in 1899 about biofilms, which we're talking about again today because the science finally has allowed us to change our perspective. And speaking of Dr. Miller, he published some papers back in the late 1890s, talked about things that are still true today that we're just now proving because of recent scientific discoveries. In fact, as we talk about the mouth being the connector to the body, we'll talk more and more about that oral disease is connected to systemic disease, et cetera. It was Miller who showed in a paper published in 1891 that if you look at how disease of the body started, you might find that a lot of them started in the oral cavity. And I guess we're seeing that today, aren't we? So Miller postulated this, and it's so much more is learned every day about the mouth's connection to the body. Let's look at the business of dentistry for a moment. This is the US market consumption last year based from the Health Policy Institute of the American Dental Association. And most of the cost, $140 billion a year spent in the US on dentistry, is in delivery of care. It's the services. 12% of the cost is in consumer products, toothpaste, mouthwashes, mouth rinses, 8% on professional products. So this is the delivery system of dentistry. Now, I want to look at the drug sales just to get some more perspective on what we're talking about today. This is a list from 2017 of the top 10 in dollars selling drugs per quarter in the United States. Abilify, a mood-altering drug, was number one. Let's focus on the second most selling drug. It's now OTC, but it was prescription at that time, Nexium. Nexium, as you may know, is for esophageal reflux, right? Esophageal reflux, the so-called proton pump inhibitor. So Nexium sold in 2017 $1.5 billion per quarter, so $6 billion a year. Now, the largest, to give you perspective on that, the largest dental manufacturer for professional products is Dentsply Sirona. Their sales in that year were $5.7 billion. So this one pill in medicine outsold the largest dental manufacturer for professional products. And that's because in medicine, most of medicine is medical management, not surgical management. Dentistry is basically surgical management. So Nexium, what it does, you take this pill, it's a systemic delivery, and it isolates in the proximal stomach and stops the stomach, slows down the production of acid. So caries, the process of caries to make cavities is also acid production. So why could we not give a pill that would slow down the production of acid in a biofilm? I think we can. And I think that work is happening now. It's very exciting. So let's come back to that. Now let's look at the focus of the 140 billion that we spend each year in dentistry based on the reason for the expenditure. If you look at it that way, then 60% of it, or 75 or 80 billion dollars a year, just from the dental fees standpoint, 65 or 80 billion dollars a year is spent on the results of dental caries, not the disease, but on the repair of the disease. It's a gigantic expenditure. Now, if you realize the fact that dentistry is only 4% of healthcare, it doesn't sound like much. But if you look at the top diseases as they present in the US, you have heart disease, about 250 billion in expenditure, cancer, pulmonary diseases, diabetes. Those are all in the 100, 200 billion dollar plus range. But oral diseases, and if you look at the Center for the Informatics at the University of Washington, which is being used for the COVID data now, they have postulated that up to possibly in the top 6 or 5 cost of diseases around the world is dental caries. It's a very expensive disease because it's most of dentistry. So if you look at caries as a disease and not as part of what dentistry does in healthcare, it's one of the most expensive diseases in the world, including all the hospitalizations. Yet most of what we do in the professional side is make products which treat the effects of the disease, not the disease itself. So I often ask audiences who are not dental people, and I think we have a few here who are in the dental business, but not dental professionals, did you have a cavity as a child? I show this picture because it's the kind of patient I see in my pediatric dental practice. You know, has a pretty good sized cavity on the distal surface of this first primary molar, and you can see it. And when most people see this, they might say, oh, gross, or yeah, I had a cavity, and they compare notes, and it was kind of, they say, well, it's kind of a nuisance. My observation is to them, it was a nuisance to have a cavity, so why am I making a big deal talking about cavities? And then I show them this picture. This is a 2.5-year-old child that we would see, sadly, often when I was in Seattle, one of the most affluent places in the country. And, you know, if kids in other countries had this and we didn't have it here, we would say, how could they let their kids do, how could that happen to little kids? This is a 2.5-year-old who came in with the swellings all over. She's going to lose all of her teeth. Fortunately, we were able to effectively treat her. She was without teeth for a while. That's a real problem. And this is a real serious medical condition. You can see how it's really a medical issue, not just a disease of the teeth. Here's another child who's now 20 years old and healthy. 4 years old, his first dental visit was to the emergency department. Saw one of my colleagues with a resident, swollen face, looks like trauma, but that's actually the results of a small cavity that spread to the adjacent tissues, causing cellulitis. And sadly, this happens all the time in hospitals across the country. This is actually a life-threatening condition. We were able to treat it. We treat it by hospitalization, general anesthesia, incision and drainage at a cost to society of $30,000 to $40,000 for a day in the hospital, all preventable for a cavity in a baby tooth. So, you know, we know the reasons why we have to do medical management. We just haven't been able to see the disease that early. So the early signs are the so-called white spot lesion. This fuzzy picture, you can kind of see some white chalky where the plaque was. If you don't remove the plaque effectively, you get white spots, which is the earliest clinical sign of a cavity before it actually breaks down and cavitates. Then these are pictures, by the way, that were taken of kids whose parents brought them to us, to me or others as a dentist, because they went to their pediatrician for all their well baby checkups and immunizations. Nobody ever told them there was a problem, but you know, often we just look straight to the posterior pharyngeal wall. So here we see some actual big problems from cavities, swellings, and teeth that probably need to be extracted. And this happens very quickly. I don't have time to get into the details. And even this picture, which looks pretty good, of about an 18-month-old child, if you look on the inside, the lingual surface, you can see the first signs of cavity formation on the inside, you know, where the nipple of the bottle or the breast is placed between the tooth. And it actually causes the cavity to form where the sugar supply is. So we have to get more early intervention. This is a child I saw who at 6 months old or 7 months, first teeth coming in, they chipped their lower incisors. I told mom, you know, we can smooth that off. Not a big deal. It's in the enamel. We can wait to deal with it. It might be an aesthetics issue later. But the truth is, I'm glad you came in, because now we can work with you in this well baby checkup to keep your child cavity free the rest of their life. And that's our real goal. So this picture, and I apologize for the little bit of fuzziness here, you can see the white spot where the plaque was. Before we removed the plaque, you couldn't see the white spot. And when we remove the plaque, you see a white spot, and then here you can see how it's cavitated. It broke down into a cavity. Once it breaks down, we have to fix it. If it's still a white spot, we can use medical techniques to reverse it. And even before a white spot, if we had technologies that would allow us to see the process earlier, and that's what's exciting and what's developing, we could actually treat it with medicinal therapeutics. And those therapeutics are evolving very quickly. We also need to talk more about saliva. I could do a whole hour just on saliva. We're getting our colleagues to chart if there's enough saliva, if it's too thick. I started a Facebook page that I have to have my colleagues help me reenact called Saliva is Your Friend. I told a parent a long time ago, this is 10 years ago, every week I tell parents, saliva is your friend, the body's natural cleaner, remineralizer that heals the cavities from becoming cavities. We should thank our saliva every day. And I actually get kids to say, please, thank you, my saliva. It sounds dumb, but we're gonna learn a lot more about saliva. They're gonna be salivary tests for all kinds of systemic conditions. And as you probably heard, there's a COVID test that's salivary based, and dental offices, dental hygienists, others will be doing these kinds of tests. Risk assessment tools. If we're looking for the risk of you getting a cavity down the road, of your child getting a cavity down the road, most of those tests are highly sensitive, but they're not specific. They give too many false positives. And without going into too much detail, that's what's important for you to know. We have to develop a better, more specific test that says, if your child shows by virtue of this test that you're going to get a lot of cavities, if we don't change your behavior, it's probably true. Okay, there can't be too many false positives for our payer system. In fact, this test developed by the Pediatric Academy shows that if you screen them and they have one white spot, which almost every kid has one, they're at high risk. So you can see it's overly sensitive. It's going to pick up too many is not really being at high risk. And the same thing for this very famous test out of UCSF that's highly reliable scientifically. It's very lengthy. Most practitioners aren't going to do this. And it's overly sensitive and not specific. So we've got to get to the technology level. There are some tests around that will help us determine which of us is at risk for getting a lot of cavities. There's a great one out of Japan from 20, 30 years ago called CAT21, unfortunately not available in the US because of regulatory things. But it's basically a simple test that doesn't care what your biofilm is made of. It just says we have a solution of 20% sucrose in this blue tube. You take a sample of the plaque of the baby or the adult, and you put it in the tube, you incubate it for 2 days, and then you get a color change. And the color change, you see here, 0, blue, and if it goes to 3, really means that your biofilm, your plaque, makes a lot of acid when you give it sugar. So we're feeding your biofilm sugar, that sample from your mouth. How much acid does it make? That resembles how many cavities you might get, because it's all about acid production. And this is in Japanese, which I can't read. But I think my friends in Japan told me this says, Mr. Mutans, that's strep mutans, goes poo-poo on your teeth. And that, I've been telling kids that for years, and now I actually have a document to prove that's what's going on. But the point is, there's a process here, and we have to get everybody to understand the process before they get the results of that process. Rather, we build these beautiful operating rooms. We built this in Seattle. We had 3 rooms like this. We did 2,000 cases a year that we treated under general anesthesia, 2, 3, 4-year-olds with 15 cavities. And we know there's a way to figure out who's going to get them earlier. And I'm thrilled that the technology is now going to allow us to do that for adults too, because dentistry's focus has shifted from focusing only on the results of disease, that is, restorative dentistry, root canals, fillings, to preventing fluoride in the water, fluoride toothpaste. But now we're looking at the risk factor, reducing risk factors. And you know what the risk factors are? They're what we eat, diet, hygiene. That's something that we can really change, how people take care of their teeth to reduce their risk factors, and fluoride and other medicaments. And I think in that order, we have to talk about those 3 things as being very important, because dental caries, unlike other conditions that we might get, is preventable. It's pretty much a preventable disease. And I'm thrilled that technology is going to allow us. There are 2 parts in common with the 2 most common diseases in dentistry, that is caries and periodontal disease. They both have an infection that a biofilm is responsible for. A bunch of bacteria in our mouths are responsible. We'll talk about biofilms in a couple minutes. And they have a host response. How does the body respond to it? But here's the difference. In periodontal disease, it's an exaggerated host response. So when the biofilm is encountered, the body, the neutrophils, are not as smart as the biofilm, which tells the neutrophils to destroy the tissue. So it's an over-exaggerated response of the host tissue to the biofilm. Whereas with caries, as we start to demineralize, before we cavitate, before the tooth forms a cavity, microscopically, the saliva is repairing it. So the body's response through saliva, through the mineral in saliva, is to fix that cavity. So if we could see that process earlier, that fixing process, identify how and that it's going on, and enhance that with detection and with agents, we have a whole new kind of dentistry, one that heals the cavities before they make holes in teeth, and instead of just restoring them. It's a gigantic change in the perspective of the entire profession, because all the structural changes we see in teeth that are not reversible, that is cavities, we need crowns and fillings and root canals, those are structural changes that we have to fix, rebuilding the house. They all started down here where the demineralization of the teeth was early. We couldn't see it, but if we could see it, we could fix it with various techniques, and then we would never have any cavities. That would be the goal. We need that kind of thing, because caries is not binary. It's not as if I have a child who has a healthy mouth and the next day they're under general anesthesia and we're treating them, under anesthesia to do 15 fillings and crowns and pulp therapies, which that was the story of my life most of my career. And I was struggling with that all the time. We all do. There's got to be a better way. Now, we've learned in vitro in the laboratory 40 years ago that we can do what I just said, that we can actually fix these cavities pretty well. That we can take a lesion that's big, we can make artificial lesions that are 1/5 of a millimeter, 200 microns, and we can heal them. Unfortunately, in order to see this, I have to extract the tooth, section it, and do that. So we can't do that to the patient. So we got to figure out a way to see a lesion like this when it's small, when you could never see it with our eyes, and then heal it with a medicine. We've known it's possible for 40 years. It's just doing it on a patient. That's the problem. We use old technologies to do this. X-rays, examination, et cetera. We got to get some new technologies that are more sensitive and, more importantly, more specific, that there are no false positives and they're reliable. So there's a lot of new technologies, and I wish I had time to go in detail. I'm just going to flash through these to get you excited about them as I am. There are those that use chemical signatures, that use fluorescence, they use topography, photothermal. People have looked at every angle, every form of energy to try to see these cavities that are forming that aren't visible. No hole in the tooth yet, but they're forming. And if I saw it, maybe there's a drug that would be made to fix it. So we use chemical signature because it turns out the bacteria that make cavities release these chemical compounds like footprints, like a bear's footprints in the woods. And these compounds called porphyrins tell us the depth of the cavity. And it turns out we can shine certain frequencies of light into the tooth. We can detect the level of those porphyrins from fluorescence. We can actually see how deep a cavity is, even in a very tiny stage. We've known this for 20, 30 years. So as we detect that, people say, well, how come there aren't many drugs then for dentistry to treat the cavities in the small stage? Because why would you make a drug that you can't detect the need for, and you can't tell if the drug worked? If you can't see anything, you're blind, you don't know anything about its effect. But as soon as we are able to see the lesions early, you're going to see a gigantic explosion of agents that in the dental office and in consumer products will be used to treat these cavities before they become cavities. I don't know any consumer, I don't know any parent for their child that would not want to heal a cavity that was destined to become a cavity. That means anesthesia, rubber dam, drilling, filling. I don't know anybody that wouldn't want to prevent that and do something short of that, like medical management. It's kind of like, if your doctor says you're at risk for heart disease, if you knew that you could do X, Y, Z, most people would say they would try to stop the outcome of a heart attack or something. So that's kind of where we are with dentistry, but it's all going to come to a change. We can see through fluorescence, we can get a lot of data on these teeth. Fluorescence allows us even to visualize better just by changing the frequency of the light. Exciting things going on out there. People are using photothermal techniques. This is a product on the market. It's a bit expensive. It needs some clinical data to make it more reliable. But we are able to put infrared heat into the tooth and look at the loss of conduction of heat as a mechanism to see how deep the cavity is. A lot of cool things. Here's one that's old. There's a newer version, but I'm going to show you the Radio Shack version, I call it. Not very nicely designed at that stage, but it does allow us to illuminate a tooth with visible light, and maybe we have a replacement for x-rays down the road. I see that coming. So we're also making these detection tools safer than currently available techniques. Imaging without radiation would be amazing, and I see that on the forefront very soon. Here's the use of that old diphote digital fiber optic transillumination, comparing it to an x-ray, and without going into detail, we did some work with this years ago. There's a lot of promise if we choose to invest in developing these techniques. They'll create earlier detection. Here's a product that a lot of us know about from Cavo company in Germany, part of the Danaher group later on. Cavo invented this device that's very sensitive called the Diagnodent, and allows you to shine a laser looking for fluorescence, and it gave you a numeric score that would tell you how deep the cavity is. They sold 20, 30,000 of these devices. The problem was they were overly sensitive and not specific. They gave too many false positives, so what ended up is dentists would be drilling for cavities when there was no caries lesion there. So, but we got to get them tightened up. Here's another product, Dentsply came out with one, took it off the market because, again, overly sensitive, but the science behind these things, if tested for clinical outcomes, could be very interesting. This one said, well, if it lights up green, detecting an enamel rod discontinuity, that the tooth would be healthy, and if it lights up red, the tooth would have a cavity. That would be a perfect world. We need a lot of clinical outcome data to be able to reliably say that. So a lot of these ideas just haven't been tested yet, but one or more of them are going to be tested, and we're going to have some great solutions coming up in the years ahead. Here we have Air Techniques. It's one of many examples of fluorescent devices that are plug and play now, and you stick them in your laptop and you can show a patient, great for education, that you have some demineralization. You got a cavity starting here, no cavity yet. Maybe we need to put a sealant on there. So there's a lot of good educational tools. In the future, they're going to be tools to allow us to use drugs. And the one that's been studied the most is called quantitative light-induced fluorescence, that allows us to actually see a cavity, its depth by fluorescence. They actually developed a product. Unfortunately, it didn't work in some arches, and most children it didn't work, and it was way too expensive. So we have to make devices that are inexpensive, just like this pulse oximeter that detects, they're very famous now with COVID, that detects your oxygen level in your blood, oxygen saturation level. When they came out 30 years ago, they were $40,000, $50,000. Now I saw one on Amazon for 19 bucks. So we're gonna make small devices. This does the same thing. It shines a light in your finger bed, it looks at the color of the blood, and it tells you how much oxygen you have in your hemoglobin. An essential life-saving tool you can get for $19. I think we can take the caries tools, because really what you're doing is shining energy into the teeth, looking for reliable information in terms of the depth of a cavity, and then all kinds of agents will be developed, and I know they're already being developed. Here's a product that was, I think they had 9 million of investment, and they ultimately took it off the market because they didn't invest it in the right clinical studies. But this product actually used electrical conductance to show the loss of conductance of electricity to be able to see where there's a cavity. So all kinds of stuff's been done. I worked when I was at the University of Washington. I met a guy named Eric Seibel, who's an amazing engineer, who had this fiber device that he could actually put into a tooth. First, he was using it for endoscopy of the stomach, for non-invasive inspection of fallopian tubes to look for early stages of ovarian cancer. He didn't know that cavities still existed. I said, let's take your device. He got millions of dollars from the NIH and the National Science Foundation. He's had a couple of PhD students do their PhD. And he proved the principle that his device, where he didn't even know that dentistry had a problem, could be used in it. And this is the big clunky one. We have to get down to a small hand-sized device. We did a proof of concept study showing that we could take that fiber, go between the teeth, and using fluorescence, see cavities before they're cavities. And then imagine now we can put a drug or an agent there, heal it before it becomes a cavity, come back a few months later, use the same device, see that it never actually formed a cavity. We healed it along the way. And some of the early data is coming out in that regard. It's going to take a couple more years to get there, but we want to work in the so-called no cavity zone of things. So the last part of the program, I want to talk about biofilms. And before we get there, as I mentioned, diet, hygiene, fluoride is everything. Our conversations with patients are about what they eat. Isn't that the same thing you hear the experts on the news when we're all at home now? They tell us to take care of ourselves. Look at your diet, look at your hygiene, fluoride. And I'm really excited about the changes in behavior that are going to result, I hope, in all of us in these things where we can control ourselves a little more. Frequency of sugar is important. We have to counsel everybody about how often they eat the sugar because it's frequency, not quantity of sugar that matters. I think you all know that already. But biofilms is where the answers are. So, you know, we know that there are about 400-500 different species of bacteria in our mouths in this complex milieu we call the biofilm. And personally, I had the good fortune to meet Bill Costerton, who was the kind of the innovator of biofilms in the mouth 25 years ago. He passed away a few years ago, but he and his colleagues talked to us about how these 400 or 500 species of biofilm hang out in these little mushroom-shaped things in the mouth, and we flow liquids through that is our food, that get to this the biofilm. The biofilm actually talks to itself, is a community, just like the organs of our body talk to each other. The biofilm talks to itself. It moves along the tooth surface, as Paul Studley showed us 20 years ago. It moves along the surface. We don't know entirely why. We also know that the biofilm engages in chemical signaling, that one of the bacterium over here creates these protein products, these enzymes, chemical signals that tell another one, okay, start making acid. We also know they don't make the acid that causes cavities until they get into a certain shape. But how do we stop that? So we used to think it was real simple. This one bacterium called Strep mutans or another one called Lactobacilli, they make cavities. Now we know it's a very complex thing. So I met another guy who's one of the leaders in education and research, especially of Caries science, Jeff McLean at the University of Washington. He's worked in several different institutions. And this is kind of complex, and I've worked with Jeff just to be able to explain it. I've asked him 6-7 times, am I explaining it correctly? He's the expert here. If you give glucose to a biofilm or any form of sugar, you can see the pH drop. It gets below the critical pH of 5.5, then it recovers. But what's going on with all those bacteria in the mouth when we see this pH drop based on what we eat? Because cavities start to form at 5.5. How do we stop that acid production before it has a chance to do that? So if you blow up part of that thing, and this shows some of the biofilm ingredients, some of the bacteria in the biofilm from the human mouth, and we can see as the pH drops when you give it sugar, you see bacteria go on and off. And Jeff has figured out there's this whole chemical signaling. It's like computer switches going on and off in a sequence. And as this bacterium produces this compound at 3 milliseconds after the sugar comes in, it then signals this one to do this one to do that. So by virtue of this complex analytics, they can determine, and it's mostly software analytics, he can determine which bacteria are really responsible that you can maybe cut off the signal to make acid, or perhaps more importantly, where could you turn off the acid? There's one called Veillonella that has some unhealthy components, but it has a healthy effect in that it actually is quite involved in turning off acid production in the biofilm. So what if we could go back to what Nexium did for esophageal reflux, turning off acid production? What if we could have a science which looked at that enzymatic process and turn on the production to attenuate the acid production or to turn off the acid production itself? I can tell you there are all kinds of companies that are developing peptides and other products exactly in this arena, because it was only in the last few years that the science that allowed us to understand what are these processes was evoked so that we could actually make drugs and agents to do it, to treat it. That is going to allow us to, and if you combine that with the technologies to see the cavities early, and now agents that can be made available because you can see the cavities early before they become cavities, we now have a whole new world of medical management opportunity in front of us. In the meantime, we're using agents like silver nitrate, which is old. GV Black used silver nitrate 110 years ago. We now have a more modern version of silver nitrate than was used 100 years ago. Here it shows it turns the tooth black, but it kills the biofilm. It halts the production of the cavity process. Unfortunately, you've got to get the agent to the cavity, which means it works best on teeth that already have cavities. So right now, when we can't generate aerosols for the next month, perhaps, we're using a lot of silver products to treat cavities, but they're already cavities. So the roof's already made a hole, we're patching up the hole. We're not preventing that hole from forming. We got to get better than that. Silver Diamine is a new agent that no time to get into details about it, except it's brought a broader product line and better access of silver agents which kill caries causing biofilm. So we can halt it in the progress by treating the surface. We can do a lot of good things, but unfortunately they're pretty late. What we really want is to halt the disease like we're doing today, but we want to get after the bigger problem, which is, given that every cavity we see started as something we can't see, we need to see it, and we have tools that are being developed to do that. Very exciting. And then we need to treat it in that stage. And I don't know any of us who would not rather treat a cavity before it's a cavity, before a hole, before we need a filling, before we need a crown, before we need a root canal, and be done with it, and to be able to see it, more importantly, in that stage. So there's all kinds of breakthroughs that are beyond drugs like silver diamine fluoride, which is in heavy use today, where we can apply a liquid, and in 30 seconds, we can stop the process. The tooth cavity turns black, that we've halted the process. Yet, we don't really love this. We have to use things like this because we can't use silver diamine fluoride until there's already a hole, already a cavity. So the next phase is going to be medical management after we have a cavity. But agents like silver diamine are great when we have patients undergoing cancer treatment to the head and neck. Thousands of patients every year. They lose all their saliva. Cavities just go crazy during this time frame. And silver diamine fluoride is a lifesaver in terms of the teeth, because we can halt the progression of cavities that otherwise would just destroy the teeth in a matter of months when people undergo this treatment. There are various products that are on the market for this silver diamine fluoride. They're in the consumer literature. I saw this magazine at the airport a few months back, a couple years back actually, reversing tooth decay. They're telling people, hey, don't get the fillings, maybe there's things you can do, but it was a little premature. But I like the fact that they're educating the consumer about a new era of dentistry where we not only can have surgery, which is the late stage, fillings, crowns, but we can have medical management like our physicians do. It's kind of like we've been in the world where we know high cholesterol is bad for you, but we can't measure your cholesterol level. So imagine now that we can see your level of risk, we can see where your cavities are in the early stage, we can actually help you a lot more. Right now, we have to do things like arrest them in this stage, and we're using silver diamine fluoride, which stops the progress, but it turns the teeth black, and I'm not going to get into how we can fix the black part a little bit. And all over Facebook for the groups, like 5,000 group of pediatric dentists, that's all they're talking about is how to make aesthetic things aesthetically desirable out of this initial treatment. And you can do it, but it's all restorative. I'd rather see a world where we're talking about not ever having that cavity in the first place. And we're going to be there. There's other products coming out that deal with the aesthetics of the silver. So you're already seeing some change in this direction. I've treated hundreds and hundreds of patients with silver diamine fluoride, but I can tell you, rather than doing this, I'd rather be avoiding this hole in the tooth. And staying connected with all the technologies gets me really excited. Drugs that we use to scrub patients before surgery, that povidone iodine, that sort of orangey stuff they paint on your body before surgery. Turns out that wipes out the entire biofilm that causes cavities, but maybe it wipes out too much. There are a lot of talk about probiotics. And over the next few years, because the work's going on in the background, we're going to see an influx of products in this general category that we call medical management of caries. So I won't have time to talk to you about some of the techniques today, because that's the longer version of this, but I wanted just to end up on where we are today versus where I see us in a few years. Today we're in traditional operative dentistry form, more restorative, and dentists are good at this. I love doing restorative dentistry, but I'd always rather avoid it. And we're going to see a big shift towards controlling the microbiome, the biofilm, through things like probiotics, through treatments of the biofilm to make it a healthier biofilm, kind of like Nexium does to prevent acid production in the stomach. That's on human cells. This would be on bacterial cells in the biofilm, remineralizing teeth before they cavitate. Cavities are kind of like a sinkhole. You hear about sinkholes. People are sitting having their bacon and eggs for breakfast on Sunday in their house in Florida, and all of a sudden their house caves in. And then we find out there was like a gigantic sinkhole in the whole neighborhood. That's what a cavity is, because the tooth turns out to be undermined under the surface. The surface looks healthy, but it's the underneath part, because the saliva is trying to fix the top, but the bottom is undermined. and then suddenly it collapses. We want to avoid that. We want to be able to see it. We want to be able to treat it. So all of these techniques on the left don't involve drilling. They're going to be really important right now. All of these involve some kind of handpiece, some kind of aerosol generating procedure. There's a lot of stuff we can do, and there'll be more things we can do in medical management once we get to this place of being able to see lesions and treat them as the new agents evolve. And the last thing I'll mention, and then I guess Maggie will take some questions, is I'm reading a book now on the pandemic of 1918, and it talks at the beginning about the conditions that existed in the medical world, medical science, clinical science at that time. And you may know that in 1915, the Flexner Report, which talked about the future of medicine, that is evidence-based medicine as we know it today. Because prior to that, if you look at medical schools in the early 19th century, it was all surgery. If you had good hands and you could be a surgeon, didn't matter if you knew any science. In fact, there were no science prerequisites to get into medical school. It was easier to get into medical school than college, much easier back then, because all that mattered was surgery. And then the Flexner Report said, we got to use medicine more. We have to have more evidence. And it was actually and the book talks about this, it was actually the pandemic of 1918 which solidified those changes recommended by the Flexner Report in 1915 into modern medical management in the medicine world and not just surgery. And we still have surgery, but the first approach isn't surgery. The first approach is medical management. And I think it's eerily similar to where we are in dentistry, and I believe that a lot of good's going to happen. And we've been talking about medical management, but as the science evolves, and it's only been the last few years that some of the discoveries have come out to allow us to even talk about this, we're going to see techniques to see lesions early, to see them before they become cavities. We're going to see a whole host of agents, peptides, other drugs come out to treat it. And dentistry, that is as a team, dental hygiene, dentistry together, we're going to be delivering medical solutions short of only surgical solutions. So it's really exciting times, and I look forward to talking to you about this again.